and tell us your algorithm in terms of deciding more or less what was the best procedure for each patient?
In ManVsProstate, do what you do well and do a lot of it, saving as many bladders of the now and of the future. What I tell people, we're all different. If we were all the same, we just all do the same fellowship, right? But there are folks who are ablative, extirpative, there's people who are reconstructive, and different technologies will appeal to different urologists. That's why we came up with those 4 categories: least invasive surgical therapy, minimally invasive surgical therapy, invasive surgical therapy, and most invasive surgical therapy. Have an action plan or an offering for each of those categories so you can meet the men where they are. Because once again, we're just guiding them. So I hope that helps. And, obviously, do what you do well, because there's so many good options.
I just started doing the aquablation and I really enjoy it. Started doing like 3 months ago, and I'll probably stick to it. I was doing a lot of green light before that. Now I'm doing more aquablation. I think based on the ultrasound guided, I see the big hole there. So, yeah.
I mean, some of those images are really impressive. That's a very interesting topic, which is when we talk about technologies, and you may have or may not have seen that I created the 4 elements of efficiency for the BPO care pathway. One is treatment durability, a man's vitality that we need to honor and respect and optimize and preserve, right? And we're trying to deobstruct for the right prostate, the right patient within the window of curability. That's number 3. And the last is economic sustainability. I don't know the data out there, but when we look at great technologies like aquablation, does that mean we place the technology in every hospital? Is that sustainable economically? I don't know. But I do know we have a severe backlog throughout the world. In Sweden, they've had a huge rise in retention, stage 4, UK as well. We're about to be hit by that here. We're already being hit by that if we talk to urologists around the country. Everyone's hearing about guys going in retention. Catheter rates for self-catheter going up. And so when we look at all these technologies, how do we find that right blend, right, of economic sustainability, treatment durability, man's vitality, and a window of curability? So that's going to be an interesting part for aquablation specifically as we move forward.
Are you doing any office-based procedures with BPH right now?
I do iTind. For me, that's been a great option for my situation, which may not be for others. I think it, once again, just have as many tools in your tool belt in each of those surgical categories. Like I talked about before, I like how it's actually treating all 4 areas: anteriorly, the roof, the floor, that bladder neck, bringing that down and allowing the lateral walls to relax to the side. But every surgeon, every practice is different. So make sure you have something for LIST, MIST, IST, and MOST.
Yeah, good to know. So last week we just got approved to start doing the iTind. So I'm going to add that to the armamentary.
Because every guy's different, right? So, and there are guys, when we talk about LIST as a category, that's non-permanent technologies done in the office with minimal risk. Minimal invasive MIST is going to be permanent technologies done in the office with low risk. The invasive surgical therapies, or IST, is going to be permanent technologies done in the hospital with medium risk. And then you have MOST, right, which is going to be permanent technologies done in the hospital with high risk. And so that's at least how I use it as a patient education tool. Obviously, there are unique variants from each surgeon that can minimize risk in each of those categories, but it just as a general guideline.